Okay, I do see that we're having a few attendees trickle in, so I'm just going to give it a quick moment before we kick things off, just to ensure we give everyone enough time to join. Okay, let's get things going. So hello, everyone, and welcome to a deep dive into data quality. I know I've had the chance to meet quite a few of you, but for those that I have not yet met, my name is Funke Falayan, and I am the engagement manager here at 3Terra. So I'd just like to kick things off by saying a big thank you to all of you for attending the premier event of the 3Terra Innovation Center. As health information professionals, we know that improving data quality at your individual hospitals is something that's always on the forefront of your mind. But of course, that reaching that data quality improvement comes with challenges and obstacles that you have to overcome. So when we were thinking of ways that we could better support you on your mission to data quality excellence, we came up with the Innovation Center. And that's because although we view ourselves as your partners when it comes to coding and data quality, we think that it's a challenge that requires the support of a community of like-minded individuals. So we've developed a platform to help you learn from the successes and pitfalls of your peers. Our hope for today is that you use this event as an opportunity to get an understanding of data quality challenges at hospitals across the province are facing, get an understanding of how they actually deal with those challenges, and hopefully take away a few key ideas that you can use to improve data quality at your own hospitals. So we do have a jam-packed session full of really engaging presentations. First of all, we will hear from Dr. Ken Farian. He is the VP of Quality, Strategy, and Family Partnerships at the Children's Hospital of Eastern Ontario. And he'll be discussing some of the lessons that he learned through CHEO's documentation improvement initiatives and the key enablers that led to their success. From there, we will hear from Rhiannon St. Pierre. She is the manager of health information at Cornwall Community Hospital. She'll be talking to us a little bit about improving length of stay versus extended length of stay, the challenges associated with physician engagement, and how Cornwall Community Hospital actually changed their departmental structure to better support their data quality goals. After that, we'll hear from Nancy Sears. She is the Manager of Health Information Management at St. Thomas Elgin General Hospital. And she'll provide us with a little bit of insight on her hospital's journey to transition the DQA data quality checks from actually being managed exclusively by the decision support team to being managed by the coders themselves. She'll talk a little bit about her motivation to make that change, her results, and some of the key lessons learned along the way. And last but certainly not least, we will hear from Matt Gertz, who all of you are probably very familiar with. And he's just going to share a little bit of information on some of the future initiatives that 3Terra is working on and look to get a little bit of feedback from you all on those initiatives. So just a quick housekeeping item. You will notice that there is a Q&A button at the bottom of your screen. So we encourage you to please submit questions throughout each presentation. At the end of each presentation, we'll take a few moments to sit down with the presenters and actually answer a few of the questions that you've submitted live. But that is it for me. So without further ado, I will pass things on to Ken Farian to share his key enablers for documentation improvement. Over to you, Ken.
Good afternoon, everyone. I'm just going to bring up my screen here. Can someone let me know that they can see the slides?
We can see them.
Great, thank you. I'm really pleased to be here with you today. So just wanted to give you a brief outline of what I'm going to be speaking about today. So I'll first share with you where we started from and what our motivation to improve was. Then I'll focus the majority of my time on some key highlights from our improvement journey, split into 3 distinct phases over the last 7 years. And then I'll wrap up with a summary of the key enablers to engaging the 2 core stakeholder groups that we have in this project before opening it up to some questions. So where did we start from? So, back in 2015, when I got started in this work, things were really not good. We had a very high level of incomplete charts rather, when the coders were trying to do their inpatient abstractions. And that was, 6 and 8 weeks after the discharge. It was as high as 26%. That led to a lot of inefficiencies and rework, lots of frustration, and lost coding capture at year end when there were still many charts that were incomplete. We recognized that we had really poorly designed a face sheet and poor understanding by the medical staff, combined with really untemplated discharge summaries by the learners, led to lots of confusion and contradictory information in what the coders were trying to abstract from, and really poor qualification of the most responsible diagnosis. And finally, there were really poor procedures and lack of standardization when we were engaging our medical staff about their deficiencies. And some were left feeling vilified, and really others were ignored and frustrated. And really, this is on both sides. This is not just that the physicians were feeling vilified. Some of the coders and health records staff were feeling vilified too, as you can imagine. Why did we want to improve? Well, our improvement really focused on 3 things. First, and really most important to the clinicians, was achieving and sustaining high quality care. And it was obvious from our poor documentation that we were putting safety at risk. It was leading to poor transitions in care into the community, and that these risks were actually real medical legal risks for both the providers and the organization. Next was really around our funding and our resources. This was a time of great attention in the province around HBAM and QBPs, and these parts of our funding formula were really suffering. We were viewed increasingly poorly against our other institutions like other children's hospitals when we were doing benchmarking on our cost performance. And all of this made it really hard for us to justify to government that we needed more resources when we were looking to expand programs or create new innovative programs. And our medical staff were actually increasingly attuned to this, because they'd ask for resources and we'd have to say, no, there's just no more money to buy that next thing, or hire that next individual to help them. And that was happening at a time when we couldn't expand, but we were also having to pull back, as many of our programs did not receive any sort of inflationary growth in our funding. And finally, we had our major transition to Epic planned for 2017, and we knew that with that coming to the inpatient areas, we really needed to get things right for it to be successful. And to get things right, we needed physicians and health records professionals to really be working collaboratively and not in conflict. So in those pre-Epic days, we formed a committee and we set some key goals. Those key goals were really to increase the completeness and specificity of the documentation to accurately reflect the care provided. So really tell the patient's story in an accurate way. Get it done so more charts could be coded at initial attempt. So really trying to drive that one touch mentality. And then really maximize the coding to reflect the true complexity of the patient's care and really generate more case weighting. So how we did this, we engaged a committee of medical staff from across the hospital, along with coding and data personnel, to really understand the issues and to be champions for change. We conducted a literature review and did some peer environmental scanning to learn from others. There was no point in us reinventing the wheel. We developed some key metrics for success and aligned these with our policies, reported on these periodically to show success or where things were still stuck. We worked on standardizing and really improving the chart deficiency and notification process so that we could engage clinicians in getting things done in a timely manner. We worked with them on tools and templates to really promote better documentation and solve the gaps in our data quality right at the source. We held a number of education sessions and actually did a video that all physicians were supposed to watch. And this gave some real life examples of the most common diagnoses and how different approaches to coding, depending on what was documented, would really result in case weighting and ultimately translate that into dollars. And finally, we had regular updates to our MAC and to our broader medical staff to really build that accountability that this project was important. Once we were live with Epic in late 2017, there were new initiatives that we needed to tackle to really help stabilize and then continue to optimize our progress. We worked with physician champions to design and refine key documentation templates to help ensure that the right information was captured and displayed in the right place and without duplication. We continue to drive timeliness of documentation by leveraging the really strong package within Epic HIM deficiency tools that notified physicians of what was outstanding and held them to account through their medical leaders. We shifted our educational efforts now to really ensuring that Problem List, which is a functionality within Epic, was really well understood and was being used proactively and dynamically throughout the visit to not make sure we didn't miss diagnoses. We continue to build consistency amongst our coders by holding weekly improvement huddles and monthly team meetings so they could all be on the same page. And then we aligned an Epic BSA with the operations of our health information management department to really optimize in near real time as issues came up. So if an issue came up at huddle on Thursday morning huddle, we then had a leadership meeting soon after to prioritize what those initiatives might look like, and we really tried to, where possible, make those changes, make those improvements before the next week, so they really saw that we were responsive to their pain points and their suggestions. After we were stable with Epic for a few months, we then layered on 3Terra as to really help us deliver on that final goal of maximizing our coding efforts and realizing case weighting. We initially focused on the alternate outliers, essentially identifying those cases where an alternative most responsible diagnosis would lead to a higher weight, and also looking for missed flagged interventions. And in that first year, so we put this in like in late February, early March, and hitting those May 31st deadlines, we found over 400 additional case weights recovered that first year. Now, over time, we've had smaller net gains and smaller number of cases flagged, but that's because we've had all of those earlier interventions really pay off by higher data quality up front. Subsequently, we've been looking at other discrepancies in terms of our special care units and imaging and special drugs and that sort of thing that would lead to higher case weights, and making sure that we can find those easily when we go to abstract a chart. So overall, I just wanted to share some key enablers of our success. So first of all, I think we really needed those small L leaders on both sides of the house, in physicians and in coders and data experts, to work together to be successful. We needed to build that team and give them the tools to be successful. We needed those metrics. We needed to understand where we were and where we were hoping to go, and to follow our progress along the way. And that old adage, you can't change what you don't measure, and you can't embarrass medical staff if you can't show that they're really, really behind. That was important. From a process improvement perspective, we really needed to make documentation and abstraction as intuitive as we could within Epic, given how much there was within that software, and really needed to work with those frontline clinicians and with our coders to really remove pain points. This brought us to an alignment of purpose. Data quality became important at all levels of the organization, and really helped everyone to push on improving upon it. So it was important to the frontline for the reasons that we talked about in terms of overall quality, but it was important to the CEO as well, to make sure that he could advocate on our behalf to get more resources from government. And finally, all of this was leveraging new perspectives. Frontline clinicians could now see the value of their documentation, and 3Terra and other initiatives really provided the coders, and subsequently with the physicians, with a really different view of the data to help us identify the gaps and fill those holes. So with that, I'd like to open it up for questions, but just before I do, I'd really like to recognize Barb Fisher, who was my partner throughout this project. Barb leveraged her over 30 years in health information management and data quality, and now she's enjoying retirement. She left us earlier this year, and is on many new adventures herself. She and her husband and their camper traveling across North America. And in fact, that first car scene on my opening slide is a picture that Barb and her husband took from their recent trips. So wishing her well. And with that, I'm happy to take a few questions. If there's anything that comes up after the fact, please don't hesitate to reach out to me by email, and we will be sharing these slides so that you have them as well.
Awesome. Thank you, Ken. That was very comprehensive, and thank you to Barb as well. So we do have a couple of questions here. The first one being, what was the key for you to get physician support in responding to coding queries?
So one of the things with coding queries was we realized that every coder was doing it differently. And so that led to just confusion. You know, they were a given physician could be approached by, you know, one of many of our members of our team. And, you know, the way they asked the question, the nuance of, you know, I'm asking you about the most responsible diagnosis, but they would just call it different things. And so one of our successes was to say, let's work as a coding team to develop almost some scripts of how we're going to approach a physician about a certain problem or a certain piece of missing information. And if we can get on track to doing it all the same way, then they're going to build their confidence in understanding what we're really looking for and help them then not ignore our email or our query through Epic, but then, you know, be able to respond to it because they'd be empowered to know what we're really looking for. And so, you know, it was conversations like that at our committee meeting where, you know, the coders would talk about some of their frustrations of sending and sending again and sending again. And then people on the other side saying, but I don't understand what you're asking for. And, you know, once you close those gaps, now you can work as a team because, you know, I'm saying I need this and okay, I've got that, here you go. And so that really helped.
That's awesome. It's almost like getting everyone to speak the same language. So
exactly.
That makes a lot of sense. Okay, and another question that we have is, what would you recommend as the first steps to building a good dialogue between coders and physicians?
Well, I think the first step is really, you know, understanding where you're at, you know, where are the pain points on both sides, and then looking for opportunities to how do you close those gaps? How can you have some quick wins that get everyone feeling like, okay, this is worth the effort, because it is an effort. It is some, you know, it's extra work for everyone, beyond just kind of plugging along and continuing to do things as you do, right? Change takes effort, but the benefit at the end of it is meant to be that it makes our work easier. It yields many different improvements and different successes in the goals that we're trying to achieve. So, you know, you have to get the momentum going on that stuff, and then it became, you know, just part of the routine. Everyone knew I was going to stand up at the medical staff quarterly and give an update on how we were doing for documentation and coding, and how we were doing on our timelines, and how we were doing on case waiting. And so they came to expect it.
That's awesome. And that is it for the questions for today. So thank you so much for your presentation and for taking the time, Ken. We appreciate it. So now I will introduce our next presenter. That's going to be Rhiannon St. Pierre from Cornwall Community Hospital, and she'll just be talking to us a little bit about length of stay versus expected length of stay, physician engagement, and changing the Cornwall Community Hospital HIM departmental structure to better align with their data quality goals. Just be a moment while we get it all set up.
Hi, everyone.
It looks like we're having a little bit of lag. It'll just be a moment before we get things set up there.
Hi, everyone. My name is Marianne St. Pierre. I'm the Manager of Health Information Services and the Privacy Contact here at the Cornwall Community Hospital. And we were approached by 3Terra to join in the conversation about a deep dive into data quality. So that brings me to the next slide here, which is the three broader themes that I'm going to be talking about today: length of stay versus expected length of stay, physician engagement, and departmental structure. So our first theme here is about length of stay versus expected length of stay, which is a conversation that every hospital has had and probably continues to have. This conversation occurs at many levels through the organization and truly does require a collaborative approach to make any impactful or sustainable change. You can see here that we did have a bit of a problem, and this was really identified in 2018. We had majority of physicians whose variance was skyrocketing, and it was very high. And the organization fully expected that the ministry would pick up on this. And while we were vying for more beds, their response undoubtedly would be, we're not giving you more beds until you can function efficiently. And this being really a very clear measure of efficiency, or considered to be a measure of efficiency, we needed to improve on this significantly. So we began to really deepen our understanding of what factors possibly influencing these results. And as we did that, really the quality of coding and abstracting was questioned, and the validity of the data was under the microscope. So the other contributing factor that we found was physician documentation. So we're really starting to develop a good understanding of our problem and starting to recognize some opportunities that would allow us to improve. And one of the approaches was to enhance our business intelligence and analytics portfolio. So this is really when 3Terra came in. We started looking to 3Terra for support in late 2018, and we had QA up and running in early 2019. We were leveraging this tool right away, and it supported both the analytics side as well as the optimization of coding and abstracting. So we began building a process that was allowing us to identify cases that needed a second look, and this is what really led us in the direction of being able to say with confidence to the organization that our coding practices are strong, and we also continue to look for ways to improve upon them. This slide really is because I couldn't very well show you all of the red from the previous slide without saying, you know, this is where we are now, and we really have improved. We've come a long way since 2018. And although this isn't at the physician level right here in this slide, and we do still have red, the improvements have been significant. The purpose here is not really to look at the actual numbers, but just to recognize that we've seen enhancements, and really was because the organization took a comprehensive approach to this problem. The next theme that I wanted to talk about was, or is, physician engagement. So this is an area that we've also put a lot of effort towards, and it has grown so much over the last 4 years. We now actually are at the point, and many individuals in the department will say this, we have physicians in the hall who will stop us and ask us about their length of stay, and it's so wonderful. So we're really at a good place with our physician engagement, but we didn't arrive here without detours and setbacks. So the first point here is our Medical Quality Assurance Committee. So this committee is a very big consumer of data within the organization. And while we bring a lot to the table, and these committee meetings are always, the agenda is packed with data and information, we wanted to spruce up the deliverables, so bring something new to the community, a little bit fresh. And this leads me to the second point, which really was one of our biggest missteps, I think, which is hospital harm. Many of you will be familiar with this indicator. So it is or was developed by CIHI several years ago and measures the rate of acute care hospitalizations with at least one occurrence of unintended harm during that stay that could have been potentially avoided by implementing best practice compliance. So it's a complicated indicator, and the methodology is quite a bit to read through. But at the end of the day, it's a valuable indicator in that it will allow an organization to potentially avoid harm to its patients. And that is really what we're all about. So we have a wonderful report in DQA that supported gathering this required data. We put together a beautiful package outlining how we could move forward in a meaningful way to help us avoid harm to our performance and all of these good things. And we were ready to present. And the day came that we brought this to Medical Quality Assurance Committee. And it went so unbelievably poorly. So bad, in fact, that one of our most vocal physicians approached me after the meeting, sort of just acknowledge the disaster and apologize on behalf of the group. And I think really what seems to have happened was that it was something that we should have anticipated, probably, but no one likes the word harm. And that, I think, was at the heart of the matter. And so shortly after that meeting, we had a meeting with Matt from 3Terra, and we were just discussing DQA, sort of what we were doing, how we were using the products, and all of that good stuff. And this meeting came up and hospital harm came up. And we had a very good conversation about maybe how to position this better to the physicians to make it a bit more palatable. And we had an approach that we sort of planned out. So we had this really good conversation, really good plan, and acknowledged that maybe harm wasn't the best word to use with the group, and fully understand that. So we had this good package all put together, and all of this sort of happened just pre-pandemic. So while we have a plan to position this indicator better to the group, we had to back. At this point, though, we are ready to dust it off and bring it back, and hoping that it will be in a more meaningful way that will engage the team rather than going down that maybe bad path again. So all of this working towards physician engagement, hoping that the conversations will happen and that they're positive. The final point here is regarding HSMR. So again, many of you will be familiar with this indicator. This is the hospital standardized mortality ratio. So the ratio of actual deaths. We were bringing this periodically to the Medical Quality Assurance Committee. We also were covering all deaths on a monthly basis. So the way the committee was approaching the death review was really very basic and arguably not material or systematic. So there is another report in DQA that is called the Hospital Mortality Analysis Report. And what this does is allow us to identify the cases that would be considered low risk HSMR deaths. And this really facilitates a more strategic approach to the committee's death review, which is really beneficial because we're using our time in a more meaningful and valuable way. So those are just some of the approaches and tools that we've used to support that greater physician engagement within the organization. It's really a road that we continue to travel, and we're still implementing new processes and ideas that are helping us along that path. And that really leads me into the next topic, which is departmental structure. So in 2018-2019, we implemented a clinical documentation improvement specialist role. So one of the HIMs from the Health Information Services team completed the certification and took on this new role and all the work that we decided would be included in that role. So the work was implemented as part of the duties for this individual. And it really included using DQA to optimize the coded data, leveraging the knowledge that was gleaned through that certification, and coming up with more novel ways to approach our length of stay versus expected length of stay, and working with the coders to make necessary changes to practices. We also around that time identified a gap that we had in the department. We had a really strong HIM and HIS and analyst piece, but we were missing that more technical knowledge. So what we decided to do was to post for 2 business intelligence analysts. The intention here was to hire individuals who were able to better back-end reporting and data storage, do that visualization and dashboard design, and really support us in a more statistical analysis piece. So we were fortunate in January and February of 2021 to find those 2 individuals. Neither had any healthcare experience, so it was a big adjustment for them. We also worked here with 3Terra to try to come up with some ways to expedite their healthcare training and just to have them be able to better understand that it is really like a whole other language that they were learning. So they've come a really long way since then. As much as possible during the pandemic, we immersed them in healthcare. So they were on site again as much as they could be, and we really were trying to get them to understand that piece. We also, in March of 2021, implemented a clinical data coordinator role. So this was to fill another gap that we identified, which was one that just sort of was going to keep things running. So keeping the information flowing and doing the supplemental data quality work that needed to be done. So this is a critical role to make sure that our wait times is submitted on time and is accurate, and really, again, just doing that coordination of all of this data and information, keeping things running smoothly. So at this point, it's a matter of working on ensuring we continue to fill those gaps with the expertise that we have. Really, we have many skill sets and much work, and we continue just to sort of shuffle things around until we find the right spot for everything. So next steps. I think we've been very fortunate to be able to implement new roles and bring in new skill and new software over the past few years. We're leveraging the software and the knowledge that we have to push forward and continue to strive to meet our departmental vision of providing timely access to complete and accurate health information, which allows us to contribute to the broader organizational vision of providing exceptional care always. And that's it from me. Thank you everyone for your time, and wishing you nothing but the best on your data quality journey.
Thank you for that presentation, Rhiannon. I apologize, everyone. We've gotten a few messages about the audio quality, so we will make this presentation available afterwards so everyone can kind of revisit the content. So I just want to take a few moments here to do a quick live Q&A with Rhiannon. If we can just turn our audio and video on. Awesome, thank you. So we do have a few questions here. So in your slides, you had actually mentioned that one of the ways that you dealt with your length of stay versus expected length of stay variance was through coder directives and coder education. Could you talk a little bit about what that looked like?
Absolutely. I think, yeah, like I said, we had a comprehensive approach to tackling that problem. And as I mentioned in the presentation, one of the things that came into question was the quality of the coded data. So, and I think that's going to happen at every organization. So what we really did was we tried to reassure everyone, you know, our coders are up to date on the standards. They know what they're doing. And so 3Terra really did support us in doing that, so we can run these data quality checks. And so when we were showing the physician group and the rest of the organization and senior team where what we were missing and what we were gaining, it was a bit reassuring, I think, to everyone to see, you know, yeah, we are able to capture what we're missing, but also we're doing very, very well. And the other part of that, I think, is just consistency. So being able to make sure that the coders are all on the same page and managing these different cases the same way. And that I can mention having, you know, monthly and weekly huddles, different groups. And so I know the coding team is really, really good at ensuring their communication is strong, that they're always reaching out to each other and, you know, trying to be consistent, as consistent as possible. So I don't know if that answered the question.
It did. Thank you. And based on your experience and like what you're currently working towards, could you give us a few tips on how to address hospital harm in a way that is more palatable for physicians?
Yes. I can tell you was sort of what our planned approach is. So we have yet to really bring it back to the group. But I think really we're going to avoid using the word harm and just soften it a little bit. And I should though say that we did have one physician, our chief of OB here at the hospital, who was really keen. And so I have spoken to him about this to say, you know, you were okay with this. You were okay with us identifying the cases that fall sort of within your realm, and he wanted the list every single month. So what do we need to do and how can we improve? So I think what we need to do is acknowledge that some of these cases that will be considered harm are expected and they're okay. And these are things that happen just as the nature of being in a hospital. So if we try to temper it with a little bit of reasonability, I think that's going to help on the physician side. And the plan is to sort of pick out a few of our key performers and the ones that may be less offended by the messaging, and sort of get an idea from them, like how would they want to hear this? And I think that in that sort of engagement pre-meeting is going to make a big difference with the broader group.
That's awesome. Yeah, that makes a lot of sense. It's almost like destigmatizing hospital. Yeah,
Absolutely. I'm finding that common goal, and just to say, you know, we're all here for the same reason. We want to make sure our patients are as safe as possible. That's what it's about. Yeah.
beautiful. And you also mentioned changing your departmental structure. Could you talk a little bit about the impact that bringing on business intelligence analysts have made to your team so far?
Yeah, absolutely. So like I said, these two individuals that we hired had no healthcare experience, but they did have quite a bit of technical background, and actually their knowledge of statistical analysis was great as well and strong, and that's sort of what we're missing. So it's been really good. They've been able to assist us in leveraging some technical tools like and building reports in the back end. So we have one individual who is very strong on sort of the back-end coding piece. So he's been able to use our EHR system to rewrite some reports and pull out the data that's in the system that maybe we would have struggled to get out. And the other individual we hired has a really strong data visualization background. So he's been able to support us in that way as well.
That's awesome. Thank you for answering those questions and for an amazing presentation. So I will now announce our next speaker, and that's going to be Nancy Sears from St. Thomas Elgin General Hospital. And she's going to talk a little bit about the DQA rollout to the coders. She had previously had her decision support team actually managing the data quality assist data quality checks, and she transitioned that over to being managed directly by her coding team. So she's going to talk a little bit about what that process looked like.
Hi, my name is Nancy Sears, and I'm the manager of Health Information Management at St. Thomas Elgin General Hospital. I'm here today to talk to you about our journey to data quality, moving from decision support to our coders rolling out the process. Just a little bit about myself. So I've been a HIM professional for 31 years. I really have focused, like my career started in coding and abstracting, report writing. So really focused on data quality in the middle of my career. I was fortunate enough to work on a re-abstraction study, and I've also been involved in a couple data quality review groups. Again, data quality has always been a big focus for me, and which works really well being the manager now in health records. A little bit about St. Thomas. So STAG's a medium-sized community hospital. We have 24-hour medical coverage. Our emerge department, we're submitting our NACRS data within 10 days, business days. We have a HIM team that includes a part-time data quality specialist. We have 7 full-time coders who also do QA and ROI as part of their duties, and we have 3 casual coders, which we're really fortunate to have. We have a decision support team that's managed by the director of finance, and they have 3 health information analysts. So DQA was implemented and purchased by the previous finance manager who was over health records and decision support at that time, back in 2018. My first experience actually with Truterra and DQA was when I worked at 3M. I was fortunate to have a demo of it, and I was so excited about the possibilities and how the tool worked. kind of those quick wins that all hospitals should have. So when I started in 2020, I was really excited to know that St. Thomas was using the tool. So it was really implemented from the decision support side and finance side, looking at ways to improve the data quality. How do we focus on the coded data and the review the chart in a way that's not just random and a lot of time being spent. At that time, there wasn't really a data quality specialist. So the manager had to make that decision at that time. They also really needed a tool that could give them very quickly an understanding of their QBP volumes. So this tool was perfect for that. I'll talk a little bit about the process from when decision support was managing the rollout. So decision support analysts would load all the data that was collected from the various hospital units and put them into DQA. The next day when the information was available, they would at times, and this was kind of limited to when they had time, they would start to run some reports. They would create a data quality Excel report and then send it out for coders to review. The first year this really happened probably at the end of the year when it was for the year end cutoff. So it was really limited cases. They picked, decision support used to be a coder, so she was able to look at kind of the quick wins and then send them off. The coders would take the file and make any necessary coding corrections, submit to CIHI, and then they would use the Excel that they received, document out, if it was valid or invalid, and then send that back to decision support. Decision support would eventually, or the analyst would eventually go back, take that Excel information, find all of the valid, and go back in and close those cases. So it was a little bit of a retroactive, just as needed, quick wins again, and very limited. The coders at that point really didn't know where this information was coming from. They just assumed decision support was running some reports and collecting some of this information manually. So some of the challenges, though, it was really limited use of DQA to start with. It was really, again, looking at some of the summary reports from a decision support process, looking at HSMR and the QBPs. From a coding perspective, it was really just the quick wins and what they could look at and kind of go, oh, here's some outliers, maybe have the coders pick, a few of those, to review. So, but very, very time consuming for decision support. They were spending a lot of time and trying to fit it into their day. And again, a lot of it would happen, at the quarterly deadlines or when things affected decision support, they would at that point send off information. Again, the coders were not involved in understanding the tool, what the decision was for what they should or shouldn't review. So it was, again, very decision support driven. So really finding the path to data quality, trying to understand what's the best way to leverage DQA at STAG. Again, I'm very data driven and, the data quality side. So I wanted to take some of this back into our HIM department. And, obviously it's still a partnership with decision support. They're going to help support us. But again, we just wanted to make sure that some of the data quality goals that I had were also implemented using this tool. So I started reaching out to 3Terra and we decided to, let's redesign the current process and maybe have our coders review some of their own data and quality checks, and what would that look like and how do we do the training and what would be the best way to do that. And then at the same time, I was starting to go, okay, I'm new here. There has to be more data. There's lots of data out there. How can we pull in more information to have more data quality checks? And so, doing some investigations there, talking to 3Terra, understanding what other hospitals are doing. So again, having the coders having their hands on, it would cause, it would help with less redundancy in the process. So again, decision support didn't have to touch it twice. Coders touch it once, back and forth that way. Decision support, they were overwhelmed anyways. They had so much other analytical things that really were important to be focusing on. COVID COVID was causing a lot of extra reporting needs from the decision support group as well. And I really wanted to empower our coding team. I wanted them to be involved in the data quality review. I wanted them to be able to look at their own work and own, you know, the things that should be reviewed. Some things you're reviewing and there's never, it's not a coder issue. It's more of a data quality issue, but again, or sorry, documentation issue. And at that point, you really want the coders to speak up and say, we're seeing this documentation issue. So then I can work with my data analyst and we can say, hey, you know, how do we improve it from, you know, documentation all the way through. And again, I really was focusing on, you know, quality first over quantity. And, you know, I have some coders that's really hard for them. They have a way of going, okay, you know what, I need to do 100 emerge charts today and I'm just going to fly through them. But the nice thing is, at least at the month end, they're able to go back and make some of their corrections. You know, I have other coders that will spend more time thinking it through, and, you know, their quantity is down, but then they're not spending the extra time at the end of the month reviewing as well. So again, different coders, different things. So going back to kind of how did I get the coders involved? And it started off, you know, we gave them a little demo and I was all excited. And I was just like, oh, this is so exciting. You guys are going to learn more. And of course, they're like, oh, we've got deadlines to do. And we've got so much more to do and you're going to give us more. So I gave them some training, you know, and I kind of walked around every once in a while and say, hey, are you getting in it? Like, do you understand it? And that kind of, you know, let them kind of get used to it. What I thought they were getting used to. And then I find out in like a month or two later, I'm like, okay, I see this big, huge list of information that no one's reviewed yet. What's going on? Everybody looked at me like, oh, deer in headlights, like, oh, you want us to actually work on all of this on top of our coding. So we had to kind of build it into the day-to-day process and, you know, our week-to-week process. It wasn't, you know, I had to allow them the time to do it. I think they understood why we wanted them to do it, but again, they didn't quite grasp that they were allowed to stop coding to look at this information. So we did some secondary coder training. We did another demo. And then we did some customization too, because the coders were like, I can see everybody's issues. I can see and I could count and kind of play with it and see, oh, wow, this, you know, coder number 3 has this many errors and coder number 4 has this number of errors. So they asked to have the coder number removed so that they couldn't see. We taught them how to go in and put their own coder number in. So now they have a new process that they can go in, see what they have available for reviewing and kind of take ownership that way. This is just a list of some of the standard data sources. We focus a little bit more on, you know, we had some interesting information about the DI procedures in eMERGE that we ended up having too many invalid. So we had to relook at that and decided that it was pulling from visit number, but the times were within that we were missing, or but they weren't part of the visit encounter, or they were attached to the visit encounter and that was incorrect. So we went back and forth a little bit on how to manage that. We also had a cumbersome process for COVID positive cases. Decision support spent manual time daily getting lab results, adding more information to be able to report it out. So we looked at, you know, how do we get a listing from the source? So that was using the pathology and lab medicine reporting tool, and had them create a report for us that we were able to import and validate. So once the coders had more knowledge, we kind of added more and more to what they could look at and review. And again, it started off with inpatients only and then moved to outpatient. Were able to take some ownership of their own data quality with the DI reporting. Started off with, like, again, just picking little pieces and progressing. Outlier report started off with, you know, a high number, a huge number. You know, it's crazy, that outlier report, but having them focus on certain numbers only. And again, it was really, really long, big numbers at that time. And then as we kind of cleaned up some of the data, we got better. you'd see here just a quick snapshot of, where we started in 2018, and then the last year's fiscal year 2020, 2021, some information. So you can see that once the coders started taking ownership, there's a lot more abstracts reviewed, some HIG recovery, and then the KBP cases, again, is kind of the focus every year from decision support to say, look at these charts specifically. But as you all know, there's a lot of other data quality that you can't really quantify here, but it helps with knowing that you're capturing the right data. So decision support, again, they're still involved. There's still pieces of things that they do for us every month. And then we wait for them for a couple of reporting. So anything to do with near miss QBPs, we don't touch until they give to us. And the same with HSMR. If they feel that there should be a review on certain months, if the numbers are not showing what they're expecting, then we would review those as well. Again, we're working with 3Terra and really promote that you take advantage of anything 3Terra can offer. They have been great with us. I'm a little needy sometimes, saying, hey, I need can you provide some more training? The coders need more training and refresher training, and come talk to me about this COVID idea I have and DI rules. Hey, there's been an enhancement. Let's have you come on site, or come, obviously it wasn't on site at the time, but just explain to the coders so they can feel comfortable continuing to use the tool. The latest actually was something that coders wanted more education. So they presented some coding funding information, just kind of overall knowledge, so that the coders could just be more empowered. We're looking at some other data sources that might be helpful to have in our system. I'd heard from Corey from North York about a Project 100 opportunity, so investigating whether that will work for our data. And then we also collect data from Southwestern Regional Cancer Program. We get that information. We also get information from our clinic, and then compared to our coding, and we struggle every month on making things balance, just even the balancing part. So working to see, if there's a way to bring in one or two of those files to be able to do some comparisons to speed up that process, but then also incorporate the data quality side from the coding perspective. So I'm kind of excited about working with them on that. And again, even a little piece of it would help us immensely. So kind of some lessons learned. Bite size when training the coders. Coders are resistant to change. So again, I was just like, change is good, and going right into it, but really the coders need more time. They need little pieces to kind of get used to it. But I think also taking the opportunity to make sure that I'm building it into their workload, and not overburdening them on that, but really promoting that, this is essential. This isn't a nice to have, it's a must. So because obviously the any misflagged interventions are huge. The other thing I learned, coders definitely learn at different speeds. Some are more technical than others. And some really embrace the data quality and love it. And there's some that don't care, and they just want to come in, do their work. They have a number they want to get done, coded, and that's that. And I also had to focus on kind of removing any barriers. So obviously the coder number was an issue for them, which may or may not be for other hospitals, but and then also embracing when they bring forward issues with data quality and being able to take that out and follow up with the physicians or whoever's doing that documentation. ALC was an area that we focused on a lot. And again, we're bringing back kind of some of the issues we're finding to say, hey, we have this in our system, but you didn't, why? And we see this, and this. So again, ALC is a big area that we're focusing on, and really build great relationships with 3Terra. They're a great team, and they're always there to help us. Again, bring any ideas to them, and they're always willing to listen. And it's been a great relationship. Thank you.
Awesome. Thank you so much, Nancy. That was a great presentation. So we do have a couple of questions and actually a few in the chat here. So the first question is, what data elements did you notice DQA made an improvement on, and where did you achieve the most gains?
So the data elements, so I'm not sure I understand the question exactly.
I think they're just trying to get an understanding of like where you saw data quality improvement.
So having the coders review their own work, they're able to see kind of where their areas were that maybe they had to spend more time on. Even for, they just found that they started to learn where they needed to spend more time. And then once they were doing better, the hard part is what I've struggled with since we've added on different elements on for the coders, we can't clearly see yet. And once I get this year's data to compare, you know, how many we reviewed in which categories, you know, which ones do we make the most changes to, and that will help for sure.
Awesome, thank you. And another question in the chat that we've received is, on average, what is the learning curve time frame for the coders in your experience?
I think ours, I'm not sure if it's the same for everywhere, but it probably was within a whole year that we did different pieces of it. Again, I didn't give them everything to do to start with. And like I said, just little bites, a little bit more, get them a little more involved. Give them more training as needed. So, you know, within the year, they were like throughout the year, they were doing some of this work, but having the reinforcement and having Tritera present again and show. And so they just really felt more comfortable with it. So some coders really jumped in and used the tool and were able to quickly understand it. What I found sometimes was some were going in, but then they weren't adding in the invalid. You know, so it's closing the loop and having sure that they're using the tool like to the fullest advantage. We've also implemented on that they need to add comments. So if they say it's invalid, they need to explain why it's invalid. So then I'm able to run reports and able to work with Tritera to say, you know, here's some that aren't working. Is there a way to remove or change the process for the reporting to eliminate those in the first place?
Awesome, thank you. And on that point as well, I know, of course, you've kind of elaborated on the fact that adoption with certain coders takes time. Everyone learns at their own speed, but would you say that there was any like explicit pushback from the coders when it came to actually taking on doing their own data quality checks?
Yeah, to begin with, and that's probably why I thought they were going to gung-ho get going on it, and only to find out they sort of ignored me and did their own thing. Yeah, there was definitely some pushback. I think part of it was just time and making sure that you give them the time and acknowledge that, you know, it does take work and it does take time, but it's important. And then that's kind of why we brought in the funding discussion as well, for them to understand, you know, the funding model and how some of this stuff does really affect funding, and the importance for the coders, importance for the data quality. We've also added on like our, we're doing some CQI as well, CDI specialists to help with helping their problems that they're having documentation side too, because, you know, we acknowledge it's not always the coder's error, it's they can't find the data or it's inconsistent within the reporting system.
That's great. Yeah, I think that finding ways to empower and educate the coding team means that it's less directive and becomes more collaborative. So that's an awesome approach. As well, you mentioned that you saw data quality improvements outside of the HIG weights and QBPs, but that you also saw other types of data quality improvements. Do you have any specific like quantitative examples that you could share with us?
Yeah, so some of the reports don't necessarily affect the grouper. An example will be my next reporting that I want, like the Southwestern Cancer Program. It's really just that doing a valid data to make sure that we have the right numbers, that they match, make it easier. It may or may not make a difference from a funding perspective. We may end up having to remove some that we thought should have been coded and they shouldn't have been. And so it's just a little bit of inconsistencies that helps with. some of the other areas too, you'll find out that it's like, oh, we have ALC on this list, but it shouldn't have been. And so there's sometimes we're removing information and going back to the source to say, did this truly happen, and then validating that. So it's not always about gaining. It's really about saying, here's the information we have, help us understand it.
Awesome. Thank you so much. So that is it for our questions for today. We really appreciate you taking the time as well. And so, yeah, now I will pass things on to Matt Gertz, who's going to talk to you a little bit about the future initiatives that 3Terra is working on.
Great. Thanks very much, Funke. And thanks very much to Nancy, Rhiannon, and Ken as well. Good presentations from everyone. And I have to say, I'm really excited and encouraged to see such turnout today. In working with all of you, the most common request that we've gotten is, Matt, can you start a community? I want to talk to other people that are using the software. I want to bounce around ideas, and to see such turnout today is really exciting and encouraging for me. I'm kind of presenting on short notice today. Akila Jamal, our CEO, really wanted to be here. Unfortunately, she's under the weather and sent her regrets. So hopefully I do the presentation justice. I want to start with, what are our goals in starting this innovation center? Because from our perspective, like what are the reasons why we would present this and put this community together? And from our perspective, it's really three different things. We are really fortunate to have the opportunity to talk with everyone amongst the community, with the hospitals that we work with. We talk to coders, we talk to managers of HIM, we talk to decision support, we talk to finance, and we hear a lot of things. We get a lot of really good ideas, and we want to be able to share what we've learned, the aha moments, and the things that we're hearing from people that we don't have a good mechanism to disseminate amongst the rest of the community. So that's first and foremost. And part of the learnings is what we're hearing. Part of the learnings is what other hospitals have heard as well. We also want to share with you, what's the direction of 3Terra? What are the things that we're working on? Where are we headed with the things that we're working on? And part of that is also understanding and getting your feedback. So the way that DQA has grown to what it is today is the community of HIM professionals that we work with have shaped it a great deal. We completely recognize that we as a vendor have very limited ability to hit the nail on the head. If we go in isolation, build something ourselves without any feedback, we're likely to miss the mark in many different ways. So, getting your feedback, and I'm going to ask for some feedback throughout the presentation this morning. So there's really two areas that I'm going to cover today, and those two areas are about computer-assisted coding and about coder productivity reporting, and two areas that we're working in and working on, and excited to hear people's feedback on as well. So, as most of you likely know, about 2 years ago, we decided to pursue what's commonly called computer-assisted coding, or CAC. And we were a little naive at the time. Our eyes have been opened a little bit, because we discovered that CAC, or computer-assisted coding, is actually a really loaded term. There's a common understanding of what CAC is, and there's an implication that there's a lot of really advanced technology behind the scenes. It uses natural language processing. It's all about processing clinical documentation, and there's almost an auto coding or bust, or auto coding or nothing mentality to it. And there's this implication that because it's advanced, it's somehow better. And the way we looked at things was computer-assisted coding is any tools that we can use to help coding teams do their jobs better. And better, when we talk about better, it's either with more speed or with improved accuracy. It's throughput or it's data quality. But from our perspective, in practical terms, that's how we kind of define CAC. And it's honestly to the point where, as much as in our marketing material and kind of how we talk to people about what we do, we've started to almost get away from referencing what we do as CAC, because it can diverge a little bit from what a common verbiage of CAC means. So long way around to say, when we embarked upon this a while back, we thought we were headed down one path, using natural language processing, doing something that was, commonly done elsewhere. But we've really kind of learned something different along the way that we'd like to share. I guess to start with this, we want to talk about a practical example of CAC. So I'm going to do this through an example, but let's talk about what CAC, traditional CAC, means in practice. And keeping in mind the two primary concerns of a coding team, we want to code with speed and we want to code with accuracy. I like to explain this with a hypothetical example of the end state. Like if we had really good computer-assisted coding, what would that mean to us as a coding team? So I'm going to do this through an example. Let's say we've got, two options here. We've got Barb. She's a really, a senior and expert coder. She codes with a great deal of accuracy. And in this example here, we're just going to talk about UTI, urinary tract infection identification, and she's 97% accurate with UTIs. Let's compare that to computer-assisted coding, and we'll humanize computer-assisted coding as Rob the robot here. He does a really good job, is able to identify UTIs at an 80% rate, which is quite good for modern artificial intelligence. And the way I'd like to explain this is let's have a competition. Let's say we have 20 charts to review. Let's have both participants review the case and try to accurately identify urinary tract infections. So from the first dimension of this, there's really no contest. It's going to take Barb 8 hours, a full coding day, to review all the charts that there are and identify the UTIs. Where Rob is able to take this work and do it in a fraction of the time because he's got artificial intelligence working on his side. So there's really no competition here. However, if there are 10 UTIs amongst the 20 charts that we're talking about, Barb is going to pick up almost all those UTIs, and let's call it 10 out of 10 in this example. But Rob finds 8 out of the 10 UTIs. So what we now have to do is say, okay, well, what are we willing to live with? We've got 8 of the 10 UTIs. Are we comfortable with that from a data quality perspective? And if data quality is important to us, what's the process that we have to take from here? So the first process is, well, we need to review the remaining 12 charts to understand where are the 2 UTIs that have been missed. So it's probably Barb that's going to take on that work. She's going to do the manual review, review the cases, and hope to find those 2 missed UTIs. And this also kind of assumes that we even know that we're looking for 2 UTIs. It may be more or less than that. We really don't have enough information to know what we're looking for there. The other part of this is, with machine learning of any kind, there is a false positive rate. And what that means is, of the 8 UTIs that CAC or Rob here has identified, there is a possibility that some of them have been falsely identified, meaning we're auto-coding a UTI where no such UTI actually exists. So we may also have to review the 8 that we've identified because of that false positive rate if data quality is important to us. Now, this is kind of a really simplistic, rudimentary example. In reality, this problem, though, gets magnified. We're just looking at UTIs here. Magnify this across all the different diagnoses that we care about. Magnify this across the different interventions that are important for us to code. It becomes a non-trivial exercise to actually integrate computer-assisted coding into our process and make sure that we're not completely duplicating the effort that we are working on currently. And I say all this to not be certainly dismissive of a natural language processing and auto coding, because we offer this. We've partnered with Microsoft. Microsoft has state-of-the-art artificial intelligence and natural language processing to help go through and scour clinical documentation, identify the clinical concepts, and suggest codes. But what I'm suggesting is this is just a single tool that we have, and it needs to be used with specificity and with intent, because there are limitations and drawbacks that need to be understood. Something that's been eye-opening for us is that there are less technologically advanced tools at our disposal that can have a lot of impact to coding teams. And that's really kind of what I'd like to share today. So I'll preface this by saying, after I go through kind of the 5 learnings that we have here. I'm going to put up a poll and just get kind of your gut reaction in terms of like how much you think this would help or move the needle within your current environment. All right, so the first tool, document aggregation. So the most basic feature request that we get is, Matt, can we just consolidate all the documentation that we have into a single spot so that we can speed up review? And this is, there are technical challenges with this, but essentially it's an integration exercise where, we're bringing data in from, your EMR, Meditech, Epic, Cerner, whatever the EMR is, putting it into a single spot. And now what we're saving is, the coder needing to go into different systems, finding different documents in the different corners of the EMR to try to identify and collect everything that they need to comprehensively code a case. This is not high technology, it's data integration, but it has a big impact because now I, as a coder, can review the documentation, be assured that everything that I need is in the single spot, and move forward that way. Getting the documents into the system is kind of really only step one. What we've heard is that navigating through all the documentation to search for particular, clinical concepts, diagnoses, interventions, whatever the case may be, can be difficult. So in the screenshot example here, we might be searching the documentation looking for pneumonia specificity. Well, the traditional way that this would be done is, go into the EMR on a document by document basis, perhaps do a search for pneumonia and try to find where things are missed. This is really time consuming. If we can consolidate everything together and just enable the ability to search across all documents for a given case, there are a lot of time savings to be had here. And this is also, by the way, an area where natural language processing can help, because when I search for something, when I search for, say, an AFib, natural language processing could help us to say, if I meant to search for an AFib, I am also interested in where an atrial fibrillation is documented. The synonyms that are in the documentation, we can be a little bit more intelligent about how we search for things. Similarly, if I search for a bleeding, I may also be interested in documentation of hemorrhage as a related term here. So cross-documentation search is something that, again, not high technology, not using really advanced techniques, but tangible value to being able to do this. Something that we didn't fully appreciate from day one, but it's come up a fair bit in hospitals that we're working with in implementing this and giving us feedback, is detecting changes in documentation. So a lot of progress notes, for example, are very similar between different entries. There's this copy and paste that happens where, we'll copy, we'll paste, we'll make changes, slight changes and variation to the documentation. And for a coder, it takes a lot of brain energy to go through each of these documents and determine the difference. It's an area where it's highly prone for error, because how am I going to look at a document where 95% of things remain the same and accurately find the 5% difference that we care about? This is also, again, an area where natural language processing doesn't help us. This is kind of an aid to show the coder what has changed in a concise way. So what we're doing is we're addressing this by putting functionality in to easily find the changes between two documents. And an example here, highlighted in red are areas where we can see pretty quickly at a glance where, documentation has been removed, documentation has been added. And this is a kind of a workflow thing where we can quickly aid in that process. Traditionally, CAC tools have focused on clinical notes, but there's also a lot of value in using what we call structured data, or data from the EMR. So bringing in data from your pharmacy system, bringing in data from your diagnostic imaging system, using external sources like, for example, CCIS to identify where ICU time may have been missed. You may not be able to directly code from these data elements, but it's invaluable to be able to identify something that's buried in the documentation that might prompt going back and looking at the documentation. Maybe it was missed the first time we looked at it, querying a physician if it's not there altogether. So we're doing our best to adapt this as well from an interface perspective to make it easier to digest the information with less mental burden. And that really brings me to learning number 5 and the final one that I want to talk about right here. Speaking of mental burden, there's an overlooked factor that's easy to fix. I'm not sure what the studies would say, but I would argue that a coder in the first hour of their shift is more alert and less tired than they would be, in the final hour of the work that they're doing. And a more fatigued coder is going to be less productive and more prone for mistakes. So, we're experimenting with things that just help aid interpretation of documentation. So, looking at the visual here, it reads to me like a wall of text, but what if we could give aids that allow us to more easily break up what we're reading, more easily digest what we have? And it could be highlighting kind of like what we have here. It could be the ability to change the font size. It could be the ability to read in dark mode. All of the aids that, other systems, your browser has built into it to help just do the coding function a little bit more efficiently and effectively. So I'm going to take a pause there. Adam, if we can put up the survey. The survey is really 5 questions that, again, if you kind of just, thought about these things that are really, at a moment's notice and thought about what you perceive the impact would be on your team, be interested to kind of hear the feedback and collect the feedback if we could take a moment here. I mean, as you're kind of doing that, another interesting thing that we've kind of seen is as we roll out our version of computer-assisted coding, we've done it in a progressive manner where, we start without NLP, we start without the highlighting within the document specifically, and we've heard, there are a lot of tools without NLP that are helpful. We'd like to layer NLP on top of it, but it can be a distraction as well. So maybe I'll give maybe 10 or 15 more seconds just to complete the survey here. And then we can move on to talk about what I'd like to talk about next, which is something that we're working on around coder performance. Okay, great. Thanks, everyone. So the second thing that I want to talk about today is measuring coding team performance. So this in and of itself could be, a full session, and I think likely it will be in the future. But what I want to do is give a broad overview of what we're doing to help analyze coder performance at hospitals amongst different hospitals. So when we talk about the different dimensions of coder performance, we see it as having 4 different dimensions. We've kind of already foreshadowed it. We care about speed, coding speed, and we care about data quality accuracy, so efficiency and thoroughness. But we also care about this from an initial coding perspective, like when the coder finishes coding the case the first time, what's our speed like and what's our quality like? But then also through our post-coding data quality audit process. Are we reviewing cases effectively? Are we comprehensively and making sure that we're catching everything that we can? So put another way, you could have a very fast coder that misses a lot of things, right? We're prioritizing speed over quality. But you could also have a very thorough coder where it's taking a long time for those cases to be coded. And our aim is to try to quantify the factors that drive this and help you establish a good balance between these different dimensions. So, how do we measure this? Well, where we're starting is in the top right quadrant here. Measuring the quality of initial coding for your team and benchmarking that amongst other members of your team, but also against other hospitals as well, because it's not necessarily going to be obvious if we're only looking internally at the hospital. Do I have a problem with a particular coder, let's say, or a particular time of the year, let's say, or do I have a more systemic problem as my coding compares to other hospitals, comparable hospitals? So how are we doing this? We're starting in the top right. We've identified that case complexity is certainly the biggest factor when we talk about coding quality. This is intuitively makes sense. The more complex the case a coder is coding, the more prone there is or ability is there is for there to be coding error. But in order for us to even measure this, we need to define what good data quality is. And how are we going to benchmark one against another? What measurement are we going to use for this? So I'll tell you where we're starting. We are starting by benchmarking initial coding thoroughness by using a methodology kind of similar to the HSMR methodology. And HSMR, for those that aren't familiar, essentially looks at what are the expected number of cases, in this case, the expected number of data quality errors that we would have for a population of cases, and comparing that against the actual number of data quality issues that come out. So where over a large number of cases, we see that there are much more than expected cases, that's going to signal an area where we're going to want to focus our time and do coder educational efforts perhaps, or coding team educational efforts to help explain this. And it's worth reiterating that this problem could certainly be at an individual coder level, but it could also be at an organizational level. You not only want to compare coders within your organization, but you also want to get a relative sense of how am I doing against our peers. And we need to control for different things, right? Different hospitals have different setups. Some hospitals have large coding teams with a large amount of specialization. There are other hospitals that have, smaller teams, maybe employ part-time coders or outsourced coding. And all this kind of needs to be factored in as we're doing this analysis. So where are we starting? We've created an initial machine learning model that's going to generate the expected number of data quality errors for a given coder for a given coded case. It's taking into account all of the factors that we see as potential to increase the case complexity of a coded case. And we've listed out at the bottom what is in consideration right now. So, the length of stay, the, age of the patient, how many comorbidities are there for the patient, and so on and so forth. And by the way, I'd love to hear in the chat or in the Q&A if there are, additional factors that, you think there might be that aren't represented on here. We'd like to be able to add to this model to be able to help identify what are the things that drive complexity, and another way of saying likely data quality errors amongst the team. Then what we're doing is we're looking at profiling and training this model based on the data from the hospitals that we work with. It would be okay to train the data with data from a single hospital. It's certainly much better to train data from a wider swath of cases, which is what we're proposing now. So if you're interested in participating, what are kind of the next steps with this? Well, you can opt in via email, send me a message, let me know that you're interested in this. What we would do is create a data file. It's completely anonymized, provided to you for your approval to make sure that you're comfortable with us using it. And then we would take that data file, we would run it through the machine learning prediction, including your hospital, but other hospitals as well. And what's the desired output of this? Well, we're going to try to identify the root cause of issues so that you can address it. What are the types of cases that are causing the most problems for you? We want to identify, targeted educational opportunities. Is it palliative? Is it home care referrals? Is there a problem with transfers in? Are there problems within particular coders? Are there problems within, different times of year, or other factors that, we don't commonly understand yet? And going forward, it's going to initially be something that we do retrospectively, but going forward, we'll also have the ability to do ongoing monitoring. So, if you've got a new coder join your team, and given that we refresh data on a nightly basis, we could tell you, within the first few weeks, whether or not there's some sort of variation in a particular area that's worth knowing about using alerting and proactive notification. So Adam, if we can throw up the second survey here, really around, whether this resonates, whether there's, interest in measuring coding team performance in this sort of way. I'd be really interested in hearing from you if you're interested in opting in to something like this. It'll be a frictionless process. It'll be something where, we'll take the data away, we'll build a module using pure data. So it's not just something where, a particular problem within your hospital is echoing. And what we'd really like to do is share broader results from the group in the next session, which is going to be in the fall. So that's what we're working on. That's what is kind of at the forefront in the next little while for us. Be happy to take any questions, and if not, throw it back to Funke.
Okay, thank you, Matt. It looks like we don't have any questions for right now. Speak now or forever hold your peace. I think we're okay. Okay, well, I just wanted to say a huge thank you to our presenters, Ken Farian, Nancy Sears, and Rhiannon St. Pierre for being a part of this event. You guys put together amazing presentations. And just before we do let you guys go, I just wanted to highlight the fact that we will be sending you a post-event survey, essentially just to collect your feedback on ways that we can improve this session and make it even better for you next time. So if you have a moment, please take a second to just fill that out. But other than that, that is it. So thank you all for joining us today. We are looking forward to seeing you at our next Innovation Center event. Take care.